It is said that we should always start with doubt and end up with certainty. And this holds true with strabismus also, that if you're already sure that you're more likely to make a mistake, so always be slightly cautious and be slightly careful, then only you will reach the right destination. Now, complex strabismus can start at so many places, as you know, along the course of these CNS and the nerves. You can have things like skew deviation, which will be supranuclear. Then you can have CCDDs, which can arise at the level of nuclei and nerves. And you can also have acquired conditions, which can be either nuclear, or they could be fascicular, or they could be in the subarachnoid space, or in the more peripheral course in the orbit. So all these locations, by their anatomical landmarks, one should be able to distinguish where we are dealing. The problem is where. Now, in these cases, we have to be more careful about history examination, because these are situations which are a bit more complicated and misleading. So one needs to know that is it congenital or acquired, because both presentations are going to be different. You also need to look at the family history and systemic history, if somebody is having diabetes or hypertension or any other problem. In children, things like low birth weight, prematurity will be important. And another thing to keep in mind is abnormal head posture, which can be very subtle, and if you are not looking for it, you may miss it. So always look for an AHP. It may give the problem away, like a DRS. You may be able to figure out by an AHP or a 6-nerve palsy. Poor vision, of course, can be because of amblyopia, refractive error, and so many, maybe there are CNS issues. So visual acuity is very important, like in every aspect of ophthalmology. The visual assessment is very important. Then we have to look at the ocular deviation, limitation of ocular motility, and abnormal eye movements like nystagmus or some aberrant innervation. And history of trauma and diplopia is also very important. Diplopia obviously will have to be analyzed in more detail. Now, in examination, we need to have systemic evaluation, visual acuity errors, and amblyopia. AHP, I have said, we need to examine what are the components, and is it just a tilt or a face turn or this thing, chin up or chin down. Then we need to look at, is there a primary deviation and secondary deviation, and which is the fixing eye, because that is important at times, because person may be preferring to fixate with one eye for different reasons. So we need to look at that. Deviation in 9 cardinal gauges and 3-step test, and evaluation of torsion is very important in some of these cases, because this may give away the diagnosis. Then we also need to do tests for muscle function, for restriction or for paresis, or both, because some of these could have an element of restriction as well as paresis. So one needs to see how much is the restriction and how much is the paresis, and what is the consequences on the ocular motility. Now we need to look at diplopia charting, Lees charting, and in relevant cases we need to do ultrasound, orbital ultrasound, and CT scan of the head and orbit, and MRI brain and orbits, and linkage analysis in whatever cases it is relevant. Like if you're suspecting a chromosomal problem, then you have to do linkage analysis is important. So you have to tailor-made accordingly. Now, there could be diagnostic dilemmas in these cases, because there could be a mixed picture, like you may have a DRS with CFM, or those combinations are possible. So it may not be one single diagnosis, it may be a mixed picture. So we need to look in a more broader way and in a more open way. And very important to know what to treat, what not to treat, and when not to treat, because everything which you see you may not always be a must to treat it, because treating it may be more difficult, it may create more problems. So one should always know the indications, contraindications, and how we are going to manage it. Treatment can be surgical, non-surgical, so always don't rush for surgery. If there are only clear-cut indications, then only we need to go for surgery, otherwise it's better to be conservative. Now we have a distinguished faculty. They don't need any introduction. Professor Pradeep Sharma is well known. He is going to speak on third nerve palsy management. Dr. Sumita would be coming. She is in another session. She will be speaking on Duane syndrome. I'll be talking on CFUM, and Dr. Subhash Dadia will be talking on MED, and Dr. Shreya will be speaking on strabismus due to muscle injuries. So I would like